The big discussion as well, 2024, the year of elections around the world, changes. That's a continuing challenge. We see the electoral cycles, 4 years, 5 years, sometimes less because of other determinants. So we're seeing a constant shift of political parties and jurisdictions, which impacts public policy. And how does an organization made up of 194 member states around the world, when those changes are happening, and the average survival rate of a minister of health in the last decade, 19 months. When your ministers of health are changing every 19 months on average, how do you continue the policy dialogue? How do you drive policy implementation? So these are constant changes that are there, and building consensus through those political changes is always part of the pleasure and the privilege of working in WHO. But it is, it's been a challenge. COVID-19 brought many areas of consensus, but also many areas of difference.
Hi, and welcome to this edition of the Health Beats podcast, one of the world's leading international healthcare business podcasts, brought to you in association with Abu Dhabi Global Healthcare Week. You can find us on Apple Podcasts, on Spotify, and indeed wherever you get your podcasts, as well as at the Abu Dhabi Global Healthcare Week website, adghw.com. My name is Steve Gardner. I am the Managing Director of Healthcare World, and I am your host. And if you haven't subscribed already to Health Beats, please do so, because by subscribing to Health Beats, you get the opportunity to hear conversations with people like my very special guest today, who is Jim Campbell. Jim is the head of workforce for the World Health Organization, has been so for over 10 years, a leading light in the fight against the global workforce crisis that I'm sure many of you heard an awful lot about, and I'm sure we'll talk about more over the course of the next hour. Jim, how are you? How's Geneva?
Steve, good afternoon to you, and happy 2025. Geneva, a cold -3 this morning, winter upon us, but a brighter sunshine this afternoon, and gearing up, January 25, gearing up for the 156th executive board meeting of member states coming up the first week in February.
Wow. I mean, that kind of brings me to I guess, to my first question. I mean, 156 board meetings. WHO's been around for an awful long time. You've been there for 10 years personally. How did you end up in Geneva? What was your personal journey that took you to this position?
Yeah, personal journey. It's quite a roundabout. I first came to Geneva through a request from the UK government as a secondment to one of the workforce partnerships that were hosted here. And from my work at the time with the UK Department for International Development, in and out of Geneva for WHO meetings and things. And then bit by bit, I was invited to apply for a position, and about 11 years ago now, and successful application, and came in to take on the director's role. But my journey before coming to WHO was a global one, Steve. I spent 10 years working in humanitarian crisis for some of the UN agencies, for some of the health specialist non-governmental organizations. So across Bosnia, Kosovo, Afghanistan, Rwanda, and the Great Lakes, looking, public health where it's needed most, when you've got displaced populations, be that for climate disaster, humanitarian disaster, natural disaster, or conflict. And sort of working with people, working with health workers around the world to provide those key services to displaced populations. And then into the policy side, and then into government side, and then into the more strategic engagement with member states.
So I guess the sort of goal of universal health coverage, providing healthcare to those that need it most, you're kind of steeped in that from the very beginning, I guess.
Very much so. It's the constitution of WHO is all people having access, to the services and the health and well-being agenda. That includes high income, middle income, low income countries. That includes displaced populations, vulnerable groups. It's the NHS coming from the UK experience of the National Health Services, where we are still have a system that we can be guarantees that universal access, challenging as it may be, but at least that guarantee to the population to universal care.
And from that perspective, Jim, I mean, in those 10, 11 years at the WHO, what have been the biggest challenges that you've faced?
Well, I think the organization as a whole, in terms of the challenges that it's having to contend with, we are seeing, that we've just turned the calendar year 2025. We've seen the record levels of climate change, on the number of climate-related disaster, the global warming agenda. And we've been talking about this in public health for over a decade, accordingly, and that's a continuing challenge. The levels of climate change and the impact on populations worldwide, the fires that we're seeing in the US today, but the many other countries around the world still faced with these challenges. That's there. It's omnipresent now. It's continuing. It's not just disease outbreak. It is also this climate-related disaster. The big discussion as well. 2024, the year of elections around the world, changes. That's a continuing challenge. We see the electoral cycles, 4 years, 5 years, sometimes less because of other determinants. So we're seeing a constant shift of political parties in jurisdictions, which impacts public policy. And how does an organization made up of 194 member states around the world, when those changes are happening, and the average survival rate of a minister of health in the last decade, 19 months.
Wow.
So your ministers of health are changing every 19 months on average. Yeah. How do you continue the policy dialogue? How do you drive policy implementation? So these are constant changes that are there, and building consensus through those political changes is always part of the pleasure and the privilege of working in WHO. But it is, it's been a challenge. COVID-19 brought many areas of consensus, but also many areas of difference.
I mean, how do you deal with situations where member states, organisations that are part of the WHO, are not able to reach consensus? Because I mean COVID-19 being a great example of this. I'm not going to name any names, that there were some countries that took a very different attitude to COVID to others, and some that were actually quite belligerent about the very existence of the disease. And certainly there was no concord in terms of how each country would respond to COVID. How does the WHO deal with a lack of consensus?
Well, I think the WHO as an organization, World Health Organization, singular in one space, but it's complex. There are 194 member states with voting opportunities, with engagement, with a voice in the governing bodies. There are the 6 regional offices, the WHO headquarters. The differences there, but it's an evidence-based organization, Steve. It's a normative. Its mandate is around producing the data, the evidence, the standards to guide public health policy and decision making. And so, coming back to that evidence, the science of public health, the science of the health workforce, the science of climate change. It really enables then us to have to build those diplomatic consensus initiatives. As I said, political parties change, electoral cycles change, but evidence is pretty robust and continuous.
Coming on to specifically your role at the WHO from a workforce point of view, we've talked there around some of the big global challenges in healthcare. What, from your looking back over the 11 years that you've been at the WHO, is there anything in the workforce arena that you personally have been involved in that you feel particularly proud of? What's your biggest achievement in this role?
Well, my personal, Jim, I'm still smiling. I think, Steve, yeah, I'm still enjoying it. That's a personal achievement when, and it's it's been a difficult few years in global health for everybody. But the organization, my team, the team around me, my colleagues, my peers, the member states, there's been huge progress. I mentioned the 156th executive board that is coming up the first week in February. We've got 3 agenda items on the health and care workforce. And one of those is presenting the 10-year progress since the adoption of the global strategy in 2016. So again, it's an evidence-based, I can answer your question with the evidence that's there. We've got record levels this year of country engagement in capturing their workforce data, improving the strength of it, improving the quality of it, and then putting that data into the public domain, Steve. So the record levels after the National Health Workforce Accounts, that gives us the empirical data to start to make the analysis and present options, recommendations, policy guidance back to countries to get this. So, this is a concept which came from 2016, 2017. It was new thinking around, let's put data into the public domain to make sure we can all share it using sort of interoperable data standards. Now in 2024, 25, record levels, 92% of countries around the world participating, producing that. That's a global public good that stands the test of time. To get there, hundreds and hundreds of people worldwide involved, Steve. So it's not my success, it's the success of many, many billion people to produce these public goods.
So what data is included in those data sets? Is this around the number of vacancies, the number of healthcare professionals, the requirements of the future, all that kind of stuff? What kind of data sets, what's included in those data sets?
So it's a modular process, which is, again, with the consensus of experts and member states around the world. We looked at over 500 different indicators which were being utilized to describe the health and care workforce, to measure key performance indicators, etc. And we reduced that 500 plus indicators down to just over 70, and then reduced again in a second iteration just over around 50. And the key pieces of information you're looking for: how many people are employed, in what occupations, and what age, what sex, how many women are participating in your workforce, in what roles. What is your education capacity for the health professions? How many nurses or midwives or pharmacists are you currently educating, and what is the number that are graduating per year? What's your retention rate? How many people are staying in the workforce? For how long? Why are they leaving? So these 50 plus indicators that have now been standardized worldwide. If a minister of health comes to you, Steve, and says, "Oh, Steve, look, what's this is my policy issue. This is my biggest policy challenge. What's your best guidance?" These 50 indicators will pretty much give you the answer to any policy question. What's the best way to pay my workers to retain them? Maybe the policy question from the minister. This data set enables that analytical work to be done.
So out of the data sets that you've got and tracking them over the period of time that you have been, what are the key takeaways? What are the big highlights that you've been able to glean from looking at that information?
So as we go into the documents are published, they're on the WHO website for any of your audience, Steve. The World Health Organization Executive Board 156, the provisional agenda, get to the document. What are the key issues? I think, firstly, there's cause for some celebration, Steve, in terms of the progress over the last decade. In 2016, we recognized that there was a shortage of the workforce worldwide, but that the estimates for the SDG period were, potentially as high as 18 million shortage would still be persisting by the end of the SDG era. That's coming down. During COVID, it was coming down. And now just this data for 2023 now, which member states have given us, again, progress worldwide in terms of the increasing number of jobs in the health and care economy. So a cause for celebration. But that Then, as you disaggregate this information, we start to look at it. But that is not equal progress worldwide. So high and middle income countries where purchasing power and growth and GDP is still there, continuing to invest in the jobs responding to the population demand, aging, communicable diseases, all the needs that are there, increasing number of work. We're not seeing the same in some of the lower middle income countries, Steve. There's still huge demand from the population and growing population. Population growth in Africa is still growing and accelerating, which high income countries don't have. And so Africa is sprinting just to maintain the capacity of its workforce, but not getting ahead of the population growth. So that's cause for concern, is that not all countries are equal in this rise. And then, of course, migration kicks into this agenda, communicable disease patterns, climate patterns. The demands on some of those low-income countries in terms of the burden of disease, less wealth, less resources, higher outward migration also starts to impact the service.
So in terms of that global trend, because obviously I remember actually the first time that I interviewed you probably was about 7 or 8 years ago. We talked then about the crisis and the numbers. The overall workforce crisis, from what you're saying there, has eased slightly. Is that in general because we have a smaller requirement than expected, or because we have more people coming into health and care?
I think if you go back to, just to qualify it, has it eased slightly? We're in a different set of circumstances after the pandemic than we were when we were talking about this 7-8 years ago, a decade ago. Yeah. Even 20 years ago, there was a clear description of the first debate in 2004 around a workforce crisis in the assembly. So 20 years ago, the first workforce crisis. That was when we were talking about maternal health, and we were talking about under 5 mortality and a crisis in relation to those indicators. Today's challenge, we keep elevating the level of expectation. We want to deliver on public health. COVID-19 has made it absolutely clear. We want to deliver on climate and climate resilience. Clearly, we've got an aging and a sort of the epidemic of non-communicable diseases, which has continued to present new challenges. So maternal health is still a challenge, under 5 mortality, but we keep adding these additional layers of expectation to satisfy the populations we serve. And so the workforce question, have we got enough for maternal health, was one crisis. Now it's, have we got enough for maternal health, child health, non-communicable disease, aging, climate, public health? And so it's a different expectation and a different response. And there is some concern that there is a continuing crisis across high-income countries, let alone lower middle-income countries, in response to these new demands on the health system.
It's an interesting point. I'm going to just pause for a second on the public health issue. I think where you are in the world and how your attitude towards public health, both in terms of screening programs, preventative health, healthcare education, can differ dependent on the system that you're involved in. So one of the things that I've spent a lot of time talking about of late is that when you look at a free at point of delivery system where payer and provider are the same, then there is clearly an incentive to create preventative healthcare models that reduce demand into the system. Mm-hmm. How do you do public health, though, in a system like the US or certain economies of the Middle East when they're insurance-led? And there is a disconnect between payer and provider. Does that not create an endemic problem in itself in terms of how you can do public health?
Well, that is indeed a key challenge. What are the market conditions, the market circumstances in the different jurisdiction, and what policy levers does a minister, a government, a treasury, a cabinet, a president, a prime minister have at their disposal to respond? And the key thing there that you may state is public health is a common public good. Whether you have a constitutional jurisdiction or a legislative one, the commitment to serve the citizens of your jurisdiction. It is public health is a requirement of government. It's a requirement of parliament. It's a requirement of the governing bodies there. So the policy lever to push that public health perspective when market conditions are not necessarily engaged in those investing in those resources because they don't see a potential return from a commercial monetary profit perspective, puts more onus on the public service, the public body to then do it. But it has to be done. You can't opt out of public health at all.
But ultimately, as you say, the responsibility to keep the population healthy rests ultimately with the government. You can't rely on the private sector, on the insurance companies, on the payers to provide that kind of basic information, screening, and so on.
But I think we've learned from the COVID-19 pandemic and the economic impact of that we all have a vested interest in prevention, preparedness, public health, because the damage that it can do to socioeconomic conditions, to populations, to profit is real. So the government has the stewardship role, but there is an opportunity for public bodies, private sector bodies, faith-based organizations, the third sector organizations to actively participate with community, with families in this to get it done. So the government is the steward, the government is the lead, but really engaging with all of society in its implementation.
I mean, the common problem that I've certainly seen in insurance-based economies in the past is that when it comes to screening and prevention, that corporate insurance companies look at it. You've got an average lifespan of 2 to 3 years under which a patient will be under their stewardship as a payer, and that by paying for preventative public health, what they're essentially doing is saving their competitors money, which is possibly the most ridiculous argument I think I've ever heard. From my point of view, I remember saying to one particular Middle Eastern government they needed to get all of their payers together in a room and bang their heads together and tell them that if they all do this, they all save money. But I guess, again, in much the same way as the WHO has to get consensus from governments, it's difficult to get consensus from a group of corporate organisations.
Indeed, I mean, it is the way of the way that we've created the health economy globally around the world, and out-of-pocket expenditures in healthcare are greater than public expenditures in most WHO regions almost now, and growing. But what we've got to make sure is that out-of-pocket expenditure is not necessarily creating or disrupting access to services. So there can be a component of out-of-pocket expenditure, co-fees, co-payments, contributions, choice around different packages and different elements, but we've still got to go back into the common public good and how do we get that funded? Prevention, promotion, water, sanitation, food safety, agricultural safety, One Health programs, all need to be funded.
It comes back, as so many of these things do, to the question of incentives and organisations that are looking after their own particular agenda, which kind of leads me to talking back onto the workforce point around, you talked about the differences between some of the lower and middle income countries and the higher income countries in terms of their position as far as, the workforce crisis is concerned, in terms of their both their need for healthcare workers and their level of production. How does that kind of split out, and how does migration fit into this conversation? Because obviously a lot of those higher income countries are reliant on migration and bringing in healthcare workers from lower and middle income countries. But of course, what we don't want to see is those lower and middle income countries not having the workforce that they require because those people are being taken away by the higher income countries. How does all of this fit together?
Well, indeed, every jurisdiction, every economy is trying to get the optimum workforce to respond to population needs within the resources that they have. But if we're some of the realities that we're seeing in the evidence and the data from countries as they share this with us, we've got an aging population in many of the high income countries. If you look at the demographics, so we've got an aging population putting more demand, but then let's look at the aging of the health workforce population. And many high income countries now, where they'd reduced the education capacity and the pipeline and the graduate numbers over years, and kept costs marginally down, have ended up now with a far higher number of their health workers in the next decade retiring accordingly. And that's going to create a major, just as you're putting more demand, the climate, the NCDs, the aging, on your health system, just as we're coming out of COVID with all this level of disruption, the stress, the anxiety, the pressure that workers have been put through, you're going to lose those decades of experience, and they're not being replaced because people undercut and under-resource their education. So now you're suddenly playing catch up because you haven't got the graduate pipeline continuing to produce. You've got the retirement aging, the retirement crisis of your workforce, your expertise from your hospitals, your public health programs. What are you left with? You turn to the market. You turn to the international market to recruit. And that may be within a regional economic area. The Germanys and Frances of this world can recruit from each other in the European, South America, African countries, etc., within their regional economic areas. But if you haven't got that, you turn to the international market. And this is where we see some of the Gulf states. You've mentioned the partnership with the Arab Health here at the top of the hour. Some of the Gulf states, huge dependency on international recruitment because they don't have their education, they don't have the sustainable workforce for the future. You look at some of the numbers from 10 countries around the world are responsible for 70% of international migration. The UK NHS being one of them. So if you haven't looked at your education and your employment and your distribution of employment through a demographic lens, crisis is real today. And then this international migration goes up.
So from that point of view, from your perspective, is migration of healthcare workers, particularly when we're talking about migration of healthcare workers from those lower and middle income countries to higher income countries, is that a good thing or a bad thing?
It's both, Steve. And we really want to, again, come back to the evidence. It's, the reality is that the migration, when we talked about the crisis in the workforce 20 years ago and the brain drain and the poaching of health workers from Africa and Asia to high income countries, we always recognized twinning and partnerships and offering education development opportunities, human capital development is a positive.
Mm-hmm. Yeah.
There are many OECD countries have long had those international engagements from the colonial era where they supported specialist education of physicians, specialist education for other occupations. So it's always been a very positive, the reciprocal agreement. But when it becomes a consequence of poor workforce planning and education planning, and your own domestic market is unable to supply, and you turn to the international market, if you're actively recruiting from somebody who has 1/10 of the workforce that you have currently, that is likely to have negative impact. And this is where we see if hospitals are having to close their theatre capacity, if hospitals are closing wards, if primary healthcare systems are unable to recruit general practitioners because they've been swept up from international migration, that's a negative. We have to look at and say active recruitment has to at least be managed, mitigated against that. Reciprocal twinning, training, excellence, experience, exchange, absolutely, please continue, but don't do damage to something. The do no harm principle of health. make sure that you are taking ethical decisions around impacting other health systems.
And from that point of view, is it your job as the WHO to be the arbiter of what sustainable workforce models look like? How is this policed?
So I would say it's part of my mandate, and my team does an excellent job on this. Is working with countries. We've actually got an expert advisory group working at the moment. One of the reports to the executive board in February is from this expert advisory group from countries and institutions and experts around the world. We've got 12 countries representing the 6 WHO regions and then populated with other experts. So again, looking at the evidence, looking at the science, looking at the reality, and looking at the balance, both the positive elements of migration, but also some of the negative elements which are impacting access to health, which are impacting population access to health. Looking at the balance here and putting the evidence forward for that, a contemporary consensus, a continued update of our understanding of migration. We saw during COVID-19 the rush to suddenly recruit workers to respond. Then the rush to immunize our populations where vaccines were available. So again, sweeping up, making changes, bringing retired workers back, bringing students into the workforce, but also going to the international market. And then other countries saying, whoa, 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 please, we're going to put measures, moratoriums in place to stop our workers leaving our country during an emergency, because it's not fair that, jumbo jets of doctors are leaving one country to go to another to get 3 times, 4 times, 10 times the wage to respond to the same emergency. So it's a continuous update to build this contemporary consensus. And I'm looking forward to it, Steve. I really am. And hopefully Arab Health will be having a similar debate with this document that the member states will be looking at. Which sort of puts this contemporary evidence into the public domain, says, look, this is the reality today in February 2025. How are we going to manage and how are we going to jointly work together around a global workforce discussion?
Because there's some interesting nuance, particularly when we talk about the Arab market. You've got countries which are wealthy, that have small indigenous populations, but quite large expatriate populations who are, by their very nature, consumers of healthcare workforce. On the flip side, you have you nodded to this earlier on in the conversation, that there are a small number of countries that are providing the vast majority of the global healthcare workforce. And in some of those countries, I think the Philippines is an example of this. The export of healthcare workers is actually hugely important to their GDP. So, how do you work out who the consumers are and who the suppliers are, and make sure that relationship is kept sustainable on both sides?
Well, indeed, again, and we see that you've got some of the key stakeholders named there, the Gulf states, the Philippines, India, Bangladesh. There are both the destination countries, the top 10 destination countries for migration, and the top 10 source countries, where we look at both supply and demand issues. And we, as WHO, we recognize that government-to-government agreements are part and parcel of the solution, rather than allowing purely the monetization of international migration, which puts different incentives into them. But government-to-government agreements, bilateral labor agreements, which look at the opportunities and the demand, the supply issues there, but where we get mutuality of benefit, Steve. So that there's this recognition of that. So the mutuality of benefits from the Philippines, as you talk about, it's the Philippines had a population pyramid, young population, high birth rates, not necessarily opportunity to employ all of them in the domestic labor market, as they were going from a low-income country to a middle-income country, and that economic progression. So they looked, okay, human capital development, let's look at opportunities for employment outside of our jurisdiction, but where they are protected, where that Philippine citizen working internationally is protected with decent work, with appropriate job conditions, given equal treatment to the workforce that they will be alongside. So whether that's in tourism, whether that's in shipping or in health, the protections for the workers are guaranteed. And then you've got to make sure those protections on the other part, if they turn up to Germany, to the UK, to the United States, to Saudi Arabia, to the United Arab, wherever they may end up, that the same protections are in place and the same terms and conditions are in place with the local population through government-to-government agreements. And that's positive because it's a thing. But then the mutuality of benefits is actually, okay, well, if you to say we haven't spent, I don't know, take a physician as an example, we haven't spent $500,000 to graduate a physician when this physician from another country arrives. Therefore, my benefit proportional to the country that I'm engaging with here, the bilateral labor agreement, is a lot better, a lot stronger than them. So maybe there's an opportunity there for co-investment back into education in that source country. It's equal.
It's a really interesting point that you raised there, because I think one of the things that we've been talking about or seeing over the last sort of certainly since COVID is some indications of where the shifts are going to take place in global workforce. So I think you and I have talked before about the fact that Africa, for example, young population, developing countries in terms of developing from lower income to middle income countries, the potential for workforce partnerships across Africa, and actually and I guess this is the question is, should those countries that are always likely to be consumers of healthcare workforce be investing in education and training in countries that have high birth rates, younger populations, training people in those countries and then bringing them rather than just relying on that supply side?
Steve, yes, I think my personal opinion on this, absolutely. I think it's and somebody like Gordon Brown, the previous UK Prime Minister Chancellor, now the UN Special Envoy on education, also an ambassador for WHO on financing health. Someone with his intelligence, with his experience, is saying, we all know education is the best dollar of investments worldwide. Human capital development, socioeconomic development, education. So if there is the African Union with its 2063 policy wants to really develop the human capital of the continent. But at the same time, that human capital with the population pyramid, how does it get a population, this demographic dividend? It's got to create hundreds of thousands of jobs for youth employment, youth engagement with greater skills, greatest competencies through education. But so there's going to be potentially over the next 10 to 15 years, Africa will have a human capital pyramid and demographics that is a prime opportunity for international work. Will have the skills, the competencies, the education, the training, the qualifications, the experience to come into some of those other consumers of health workers. In which case, let's look at it as a global opportunity. Let's not just say, okay, well, I'm going to take the benefit of that and just take the best and brightest from my economy. Let's actually look at the benefit of looking at a global workforce and co-investing over the next 10, 15 years so that everybody has an opportunity to address the workforce crisis of today. So it's in our mutual interest. It's a common public good, just as public health earlier, having a workforce for every economy, for every jurisdiction. We should be co-investing in that.
So I guess if you logically follow this argument through, we talked about the Gulf states in particular, where there is money to invest, where the smaller indigenous population, the large expatriate population, is there an argument to say that we should be saying to those Gulf states, go and invest in universities, go and invest in education and training facilities for healthcare workers in sub-Saharan Africa, and that's where your workforce of the future is going to come from.
It's supply and demand, labor markets 101, Steve. There's real opportunity to co-invest in these the human capital, which will serve national labor markets, regional labor markets, expertise with opportunity. We need to oversupply the market. The demands for health, as we talked about earlier, are outstripping the human capital capacity. And there's a competition for resources, which means the premium keeps going up and up and up to attract those resources. Let's look at it the other way. Let's oversupply the market. Let's get growth and injected, especially with countries with young populations where health is in demand anyway. Co-invest in their education institutions, co-invest in the stewardship, co-invest in the public health systems to build the experience for and that will eventually trickle over and help others. But I still think, the Gulf states, I would still like to see, and as well as all the OECD countries, there's still, you can't deprioritize your own anchor institutions, your own health economy. The investing in education and jobs, just as we've seen now with the Labour government in the UK, putting the economics of health, good health institutions, good health universities, producing people for the health institutions, adds value to your economy. Full stop.
It comes back, doesn't it? And every time to the health and wealth agenda. If you keep your population healthy, both in mind and body, then they will be more productive, and that is going to increase your GDP. And that's always the argument for investing in health, is it not?
And it has been a dominant sort of economic model, a dominant treasury thinking model. But we also know, there's also the moral obligation, there's already the public health responsibility that goes beyond the wealth argument. But yes, I mean, the evidence is overwhelming. Good health institutions, good health education institutions generates an economic dividend, which is rapid, immediate, and has longer term impact on GDP.
I mean, if you think about this in a kind of almost like a profit and loss sense, there's the piece there about, what we're talking about, which is providing the workforce, providing the capacity. Of course, the other way to increase profitability in a business is to decrease costs. Is there any possibility, is there any opportunity that we can decrease the demand on our global healthcare workforce and our global healthcare resources through the use of data and technology, through the kind of public health work and preventative agenda? Or is that just a question of you can slow down the supertanker, but you're never going to stop it? The demand is always going to increase. What's your view there?
There's not a simple answer, Steve, in one sense, but in another way there is. Investing in public health, prevention, promotion, utilities, social determinants, has guaranteed return on investment. Keeps people healthier, keeps economies moving, it keeps people out of hospitals, it delays some of those long-term costs of tertiary services and emergency services. So we know that it makes sense economically to come further forward. I think you can, and we're seeing that Wes Streeting, since he's taken over in the UK, very much saying, let's do prevention rather than treatment. Let's do local economies, primary healthcare. Let's do the economics of health. All of that is, it's been simplified down to 3 key actions, but it's all evidence-based. So you can make a difference. Every minister of health, every government can put that agenda on the table and make an immediate difference. And it doesn't take 10 years, Steve. You can make impact in 12, 18 months, 3 years, 5 years on these agendas. So they can do that. The tanker can be slowed. The tanker can be turned, to use your analogy. But at the same time, you've got to also then get ahead as you think about digital tools, digital technologies, augmented intelligence, artificial intelligence are going to help our health systems to be more productive, to get greater performance, to get better outcomes coming through if they're used correctly, Steve. And that's the key thing. We need to put in place the governance and the stewardship around some of that, so that we collaborate on some of the core issues that every country needs, and then you introduce competition for improvement around some of the upper market areas that you may want to do. But we need AI, artificial intelligence, augmented intelligence, serving the common public good first, before that we open it up to monetization, so that we're in the privatization side of it. Let's put that the public priority, the public purpose, should be driving investments in the AI potential to help everyone.
I think that I always seem to end up coming back to this question of incentives and perverse incentives, because one of the issues that I always see with, as I say, with the preventative care agenda is the market. And one of the things that we think a lot about is value-based healthcare, is payment based on outcomes, but the lack of incentive to move towards preventative healthcare, the lack of incentive to move towards value-based healthcare when the majority of the world's health economies are based on corporate insurance. How do governments and those that want to act in the public good get their payers to move towards the preventative agenda and the use of value-based care?
Stewardship and leadership is obviously the thing. You can make a difference. Your public priority, your public policy, put it out there. This is where the direction you're going, and engage with your social dialogue with all your stakeholders to get that done. But then the payers can take some responsibility. You're seeing in the US now some of the big insurance companies, some of the big health groups actively going into education of a workforce where the public health preventative medicine is the priority, because they see that by introducing that type of competence, that expertise into their workforce, it's going to have a long-term dividend for them. And we need those evidence base coming out of some of those examples to then populate policy dialogue elsewhere. It's the value-based proposition, the value-based care proposition, I think is huge potential alongside the digital tools, technologies, AI proposition, but underpinned by what workforce do we need to deliver that. It's got to be part and parcel of every discussion.
No, and it's a really, really fascinating topic, and I think if you look at the good examples that are coming out of insurance-based economies, as you say, there's some great examples in the US of organisations who are, much as the NHS in the UK is, are both payer and provider, because that automatically equalises the situation and means that they have a real interest in decreasing the actual number of people coming into the health system in the first place. The other model that I've seen that I think is interesting, and I'd like to get your comment on, is that of large corporates that have an incentive to look after the mental health of their workforce, to keep them at work and keep them productive, moving away from corporate insurance and moving towards their own health and wellness agendas, working directly with provider groups. Is that an example that you're seeing more of, and how do you feel about that?
We are seeing more of it. I'm part of a lot of case studies and anecdotal and descriptive evidence coming around some of these different models. What we're really interested, Steve, is what's the cost of that intervention? What's the results that we're starting? Are the results measured around that? When that investment starts to give us returns, what are the results that are coming out of? So we can start to unpick some of the opportunity cost and the incremental value that's coming from those different markets. At the same time, though, we're also seeing in the evidence, I think where the Minister of Health in Germany, Karl Lauterbach, was saying, the real concern around what he termed, the English translation was locust investors, where they're looking at the other way around and just extracting profit from not contributing to the human capital, not contributing to the labor market, but just extracting for the maximum return from billing to health insurance systems. And that's where we need to really look at the different issues, the different areas, and come together in a more coherent way. So both positives and negatives in this market and the evidence that's coming out.
Well, I guess that second point, the locust point, comes in when you look at traditional fee-for-service models, where we're ending up with situations where, for example, a cancer patient is having, a provider doing too much intervention because every time they do a thing, they get paid. So it's that perverse incentive issue, is it?
Yeah, absolutely.
Yeah. We're running a little bit short of time. I could go on for hours. It's always great to talk to you, Jim, and I'm sure we'll do so quite a lot over the coming year. I guess my last question, from your point of view, as you sit here now, you've been in the job for 10 years. Yeah, you've seen the global healthcare workforce change. You've seen the problems and the issues change. You've seen a pandemic. You've seen lots of different governments. You've seen some of these changes in terms of how we look at healthcare from a public health and prevention point of view. You're now seeing, I think, probably the beginnings of the climate crisis. From your point of view, what does the healthcare workforce look like in 10 years' time?
Tough question, Steve. The last question is a tough one.
You're throwing it easy for you, Jim.
Exactly. I think what we're going to see is education. I really believe. Our estimates are that somewhere in the magnitude of about $300 billion a year is being spent on health professional education and development training around the world. The rapid rise of digital tools technologies is going to make transform learning. And I think what we may see is an increasing workforce coming through with a totally different set of competencies, and they're continuously building competencies through a lifelong learning approach. But the market has got to adjust to that, and the market has still got 50 plus million health professionals around the world without those same education experience and competencies today. So it's going to be adjusting to this new competency-based, digital enhanced approaches, engaging and accommodating them. And we're going to see some tension in the differences there, but eventually smart health systems will start to be quite normal, value-based propositions, looking at health prevention promotion as the norm and trying to keep people away from expensive high-end costs. And that tension. I think in 20 years, we'd have another cycle of this, another decade coming further forward. We'll be into a completely different future. But that's to say, I don't think our position on digital tools, technologies, and AI, it's not going to replace health and care workers. We've still got the populations of the world, communities of the world, still want to engage with another human being for most of their healthcare needs at some point. That our providers, the health personnel, will be using digital tools, technologies a lot more in their interaction with communities, families.
Healthcare will always, and has always been, and will always be a contact sport. There's no two ways about that. Jim, I'm gutted to say that we're out of time. It has, as always, been an absolute pleasure. Thank you to all of our audience for listening and for watching. Don't forget to subscribe to Health Beats, and we'll see you for the next episode. Thanks very much to Jim.
Thanks, Steve. Stay well.